Welcome back to the deep dive. We're here to do what we always do. Take a complex topic, break it down, and give you the kind of clear, logical framework that experts use to make sense of it all.
And today we are stepping onto what you might call a classic surgical battleground, the right iliac fossa mass.
The RIF mass. Yeah, it's one of those things that sounds academic, but it's a really high-stakes clinical puzzle you see all the time.
It really is. I mean, the RIF is home to some critical structures
Yeah.
and a mass there.
Yeah.
Well, it could be something fairly simple and localized, or it could be something truly life-threatening.
Exactly. And you can just imagine standing at the bedside, you feel a lump in that lower right quadrant of the abdomen, and your mind just starts racing. Is it the appendix? Could it be cancer? Is it, something gynecological?
Right. And without a structured approach, that lump just feels like this dense forest of possibilities.
And that's what this deep dive is all about. We want to give you the compass and the map, the master key, really, that senior examiners and surgical consultants use to cut through all that complexity in an instant.
We spent a lot of time distilling a really rigorous, clinically practical, and systematic pathway for this, drawing from a consensus of expert sources. The benefit for you, the learner, is shifting your focus from just memorizing lists.
Which never works.
It never works. To understanding the logic of clinical differentiation, we want you to really get inside the decision-making process.
Okay, so let's lay out the framework that's going to guide us through this. We've organized this deep dive into 5 sort of foundational pillars.
Right. First, we have to anchor ourselves in surgical anatomy. We need to define what actually belongs in the RAF.
Makes sense. Can't know what's wrong if you don't know what's right. What's second?
Second, we unlock the secrets hidden in the clinical history. And this is, often the most diagnostic step of all.
Okay, anatomy, then history. Pillar 3.
Third is the physical examination. This is where we translate those stories into concrete, palpable findings.
Feeling the difference. I like it. Fourth.
Fourth, we learn how to confirm our suspicions with judicious investigations, using the right tests at the right time.
And finally, the 5th pillar, which is really the so what of all this.
Exactly. Diagnosis-specific management. We'll map out the definitive treatment pathways, and we're really going to focus on the big 3 causes that you'll see most often in this region.
All right, that's a fantastic roadmap. Let's start at the beginning. Let's set the boundaries.
Let's do it.
Okay, let's unpack this clinical anatomy. There's a core principle here, right? That anatomy dictates pathology.
It's the first rule. Before you can even begin to talk about what's gone wrong, you have to have a crystal clear picture of what's supposed to be there.
And that's our first big filter. The very idea that a mass is confined to the right iliac fossa. That already limits the possibilities massively, doesn't it?
Massively. If a mass is truly in the RIF, it must originate from the structures that live in or pass through that specific anatomical box. It sounds simple, but it's an incredibly powerful shortcut.
So if you can just list the contents of the RIF.
You've basically generated 80 to 90% of your differential diagnosis list right there before you've even touched the patient.
Okay, so let's identify those key players. What are the biggest residents in the neighborhood, starting with, I guess, the gut?
The gut dominates this area. It's really all about the junction between the small and large bowel. So at the very end of the small intestine, you have the terminal ileum.
And that's a significant spot, isn't it?
Hugely significant. It's a common target for chronic inflammatory conditions. You have to think about Crohn's disease, which just has a predilection for the terminal ileum. It causes inflammation, thickening, and eventually it can feel like a mass.
And it's also a key site for TB, right?
Yes, it's often where you see the initial lesions of ileocecal tuberculosis. So the terminal ileum is a major player.
Okay, so that's the end of the small bowel. What happens right after that?
Immediately after you enter the large bowel, and it starts with this blind pouch called the cecum.
Right, and attached to that is the star of the show, or often the villain.
The villain, exactly. The small, worm-like, and often very problematic appendix. And the specific point where the ileum meets the cecum is the ileocecal junction.
And you're saying this whole area is a clinical hotspot.
It's a huge hotspot.
Yeah.
Malignancy often starts right there, in the cecum. The reason is the fecal stream slows down significantly in that area.
Ah, so there's more contact time.
Exactly. More contact time between the mucosa and any potential carcinogens in the stool. This is why a mass here is often just called an ileocecal mass. It's a busy intersection where things get backed up or inflamed.
That makes a lot of sense. But when you get inflammation, it's not just the bowel wall itself, is it? The body tries to contain it.
The body's always trying to contain pathology. It's a brilliant system. And that brings us to the mesentery, the fatty tissue that suspends the bowel, and the regional lymph nodes inside it.
So the lump you're feeling might not even be bowel.
Precisely. It could be massive lymph node enlargement. It might be reactive, like in mesenteric adenitis, where the nodes are just inflamed from a virus. Or it could be something far more serious, like lymphoma or metastasis from a carcinoma we didn't know about. The palpable mass you feel might just be a cluster of matted, diseased lymph nodes.
Okay, so that covers everything inside the main abdominal cavity. But you mentioned the RAF has a deep secret, the retroperitoneum.
Yes, and this is a crucial point that's so easy to miss. You have to think deep. Lying behind all of this, anchoring us to the back wall, is the huge psoas muscle.
And a problem there can push forward.
It can push everything forward and present as a RIF mass. The classic example is a psoas abscess. Often that's secondary to something like tuberculosis of the spine.
Pott's disease.
Pott's disease, exactly. Or some other deep infection that tracks down along that muscle sheath.
You also mentioned the urinary tract and the big vessels.
Correct. The right ureter is coming down from the kidney. Now, it's not a common source of a mass itself, but a nasty infection around the kidney, a perinephric abscess, can track down and present as a mass or severe tenderness in the RIF.
And the vessels.
Deep down, you have the major iliac vessels. A big iliac artery aneurysm or massive lymph nodes wrapped around those vessels can be a palpable mass. Sometimes you can even feel it pulsating.
And of course, for about half the population, we have to add a whole other set of organs to the list.
This is absolutely non-negotiable. In females, you must always consider the right ovary and fallopian tube. Ovarian cysts, an ectopic pregnancy, these can present acutely as a tender RIF mass.
Or a severe infection.
A severe pelvic inflammatory disease can lead to a tubo-ovarian abscess, which is this intensely inflammatory, very tender mass located right in the area we're talking about. It's why a pelvic exam is mandatory.
Wow, so that's an incredibly packed neighborhood. But the key takeaway for me is that the mass isn't always the gut. It's just as likely to be the support structures, the lymph nodes, the mesentery, even the psoas muscle.
That is the single most important takeaway from the anatomy. If you start your thinking with, this is a pathology of the ileum, caecum, appendix, lymph nodes, or retroperitoneum, you've already done most of the work. You've used anatomy as your first, most powerful filter.
All right, so anatomy sets the boundaries. Now, you said the clinical history is the compass that guides us through it.
It really is.
Yeah.
It's often said that a RIF mass is diagnosed 80% of the time just based on the patient's story. If you can master the questions, you can almost see the diagnosis forming before you even lay a hand on the patient.
I love that. It's a true diagnostic filter. Let's start with the most basic question. Timing. The onset of symptoms.
You have to sharply differentiate between a sudden crisis and a slow burn. The question is simple. When did you first notice anything was wrong, and how quickly did it get this bad?
Okay, let's take the sudden crisis first.
An acute onset symptoms that just exploded over hours, maybe a day or two, is the signature of intense sudden inflammation. This points overwhelmingly towards appendicular pathology. Acute appendicitis that's progressed to form an inflammatory mass or an abscess. It's an urgent problem.
Even the slow burn. What if the patient says, I've kind of felt this discomfort, this lump for the last 5 or 6 months?
That chronic onset is your primary red flag. Symptoms developing insidiously over weeks or months. It immediately raises your suspicion for serious long-term pathology.
Right. So now we're thinking
ileocecal tuberculosis, or, critically, malignancy like ileocecal carcinoma. These diseases, especially cancer, take time to grow and cause a mass effect. The speed of onset is just incredibly powerful in separating the inflammatory from the neoplastic or chronic infectious causes.
That's such a clean separation. Okay, the second filter, and maybe the most famous one, is the migration of pain.
The absolute classic. You have to ask specifically about where the pain started, its trajectory, and where it ended up. The classic appendicular mass history begins with pain in the epigastrium, up high or around the belly button.
And the key is that it moves.
The key is that it migrates and then settles permanently in the RIF after a few hours. That movement is the fingerprint of appendicitis.
Can you just quickly explain the physiology of why that happens?
Yeah, it's a beautiful piece of neurology. Initially, the appendix swells, and it stimulates these generalized visceral nerve fibers. They're poorly localized, so you perceive the pain centrally. But as the inflammation gets worse and starts to irritate the lining of the abdominal wall, the parietal peritoneum in the RIF,
that lining has different nerves.
it has somatic nerve fibers, which are sharp, specific, and localized. That migration from a vague central pain to a sharp, localized pain in the RIF is the whole story.
That's a great explanation. So if the pain just started in the RAF and stayed there, it's less likely to be classic appendicitis.
You have to be less certain, exactly. And it's a stark contrast to the chronic diseases. For ileocecal tuberculosis, patients describe this dull, persistent ache. It never has that dramatic migration.
And for cancer.
For malignancy, pain is often minimal, especially early on. A vague discomfort, a feeling of pressure. That's the danger. It grows silently. Pain only gets severe when the tumor causes an obstruction or invades nearby nerves. The lack of severe acute pain should raise the flag for a chronic process.
Okay, filter 3, fever patterns. This seems pretty straightforward, separating infection from other things.
It is. High fever screams infection. A high-grade acute fever, 39 or 40 degrees Celsius with chills, that suggests a contained collection of pus, an appendicular abscess. That patient is septic.
And what about the chronic infectious culprit, TB?
That's where you look for the constitutional signs. The fever with tuberculosis is classically a low-grade evening rise. The temperature might be normal all morning, but then they get a slight fever, often with night sweats late in the day.
Evening rise. That's the key word.
If you hear that, TB has to jump way up your list. An uncomplicated malignancy, usually no fever. If a cancer patient has a fever, you have to suspect a complication, like an infection behind an obstruction.
Okay, filter 4 is a huge one. Bowel habits.
This requires very specific questions. You need to ask about persistent diarrhea, stubborn constipation, or, and this is the most potent red flag, alternating diarrhea and constipation.
What does that alternation signify? What's happening inside?
It's highly suggestive of something inside the bowel blocking the path, like a large tumor. When the stool is solid, it gets backed up, causing constipation. But then liquid contents can squeeze past the obstruction, and the patient gets what's called overflow diarrhea.
That alternating pattern, especially in an older patient, is a major warning sign.
It's almost pathognomonic for a colon malignancy. You also have to ask about blood or mucus in the stools. Frank blood points directly to a break in the mucosal surface, a signature of carcinoma.
Okay, let's move to the 5th filter, the big systemic indicators, the constitutional symptoms.
These are the signs that the disease is consuming the patient's energy. We're talking about significant unexplained weight loss and a chronic loss of appetite.
Not just, I didn't feel like eating today, like with appendicitis.
No, this is different. This is a patient who reports losing 10, 15 pounds without trying over a few months. That kind of wasting is highly characteristic of either advanced malignancy or a chronic systemic infection like tuberculosis.
And finally, the 6th filter, past history, the context.
You have to ask, have they had previous similar milder attacks? That might suggest recurrent appendicitis. Do they have a prior history of tuberculosis or known contacts with someone who did? Or are they immunosuppressed?
Because that would make them more vulnerable to opportunistic infection.
Exactly. Like a psoas abscess or complicated TB. Context is everything.
This is truly powerful. So just to summarize, acute onset, migrating pain, high fever. Think appendicular mass. Chronic onset, low-grade fever, weight loss. Think TB. Chronic onset, altered bowel habits, hard mass. Think carcinoma. The history is almost a self-guided interview.
It is, if you ask the right questions.
Okay, we've got the map, we've heard the story. Now it's time to translate that into what we can actually feel, the physical examination.
And let me just stress this, the examination must be systematic and gentle. You're not trying to wrestle the patient. A gentle approach lets you feel through their guarding. If you're aggressive, all you'll feel is a tense abdominal wall.
Right. And we start, as always, with inspection. What are we looking for before we even touch them?
We're looking at the general state of the patient. Are they toxic? Wasted? Then, on the abdomen, we're looking for distension, which could suggest a bowel obstruction. We're looking for old scars and, critically, checking for hernias. An incarcerated right-sided hernia can mimic this whole picture.
Okay, now for the main event, palpation. We need to use those classic characteristics, location, size, shape, and so on, to build a profile for each diagnosis.
Exactly. Let's start with the acute picture, the appendicular mass.
What are the hallmarks when you put your hands on that?
First and foremost, tenderness. It's going to be profoundly tender. You'll feel gall your system, guarding over it. Second, the consistency is firm. This isn't soft. It's densely packed with inflammatory tissue and omentum.
And the edges.
The margin will be ill-defined. You can't really trace a clear edge because it's a diffuse inflammatory mess, not a neat little tumor.
So, intensely painful, can't feel the edges. That's our appendicular mass. Now, let's pivot to ileocecal tuberculosis. How does that feel different?
This is a classic, memorable distinction. The texture of TB is often described as having a doughy feel.
Doughy, like bread dough.
Exactly like that.
Mm-hmm.
Think about pressing on firm, dense dough. It's solid, but it's got this slight pliability. It's not rock hard. That comes from the chronic rubbery thickening of the bowel wall and the matted lymph nodes.
That's a great tactile analogy. And what about the tenderness?
This is the critical differentiator. Ileocecal TB is usually non-tender, or maybe just mildly tender. It's a chronic process, not that acute, screaming peritoneal irritation you get with appendicitis.
So a doughy, ill-defined, non-tender mass.
Especially in a young patient with weight loss, is TB until proven otherwise.
That's a powerful distinction. Tender for appendicitis, non-tender for TB. Now the third one, ileocecal carcinoma.
Malignancy feels, it feels frighteningly clear. The consistency is hard, stony hard, rock-like. That's the feel of dense, invading cancer tissue.
And the shape.
Unlike the others, a carcinoma is often well-defined, but critically irregular. You can trace its edges, but the surface feels bumpy or nodular. And like TB, it's generally non-tender in the early stages.
What about mobility? That's a huge clue for cancer, isn't it?
It is. Cancer loves to invade and fix itself to the structures behind it. A mass that is fixed, that you can't move at all, is another major red flag for carcinoma.
So we've got a really clean, palpable differentiation. Inflammatory is ill-defined and tender. Chronic infection is doughy and non-tender. And carcinoma is hard, irregular, and fixed.
Yes, but the exam's not over yet. You have to do the special maneuvers and, crucially, the internal exams.
Let's talk about the special maneuvers. The psoas sign.
This tests for irritation of the psoas muscle. If the appendix is retrosacral behind the cacum, it's lying right on top of that muscle. So you ask the patient to extend their right hip, which stretches the muscle, if that causes pain in the RAF.
It tells you the appendix is probably in that retrosacral position.
It's strongly suggested. We also percuss over the mass. If it's dull, that confirms it's a solid or fluid-filled structure.
Now let's talk about the exams that people sometimes skip, the ones that lead to missed diagnoses.
This is the crucial reminder. You cannot, under any circumstances, skip a rectal examination or, in females, a pelvic examination. It's malpractice.
Why is it so important?
A pelvic appendix, one that hangs down low into the pelvis, won't cause classic RAF pain. It might cause rectal discomfort. And you'll only feel that tenderness or a potential abscess on a rectal exam.
And in females, it's because of the anatomy we already discussed.
Precisely. If you don't do a pelvic exam, you will miss an ectopic pregnancy, which is a surgical emergency. You will miss a tubo-ovarian abscess. Your examination of a RAF mass in a female patient is completely invalid without it.
So by now, we've translated the history into a clinical feel. We have a very strong working differential diagnosis.
We do. And now we move to confirmation with investigations.
Right, because clinical suspicion is one thing, but you need objective proof. Let's just run through that full differential diagnosis list one more time to make sure we're thinking broadly.
Okay, our structured list is 1. Appendicular mass, 2. Appendicular abscess, 3. Ileocecal tuberculosis, 4. Ileocecal carcinoma.
Those are the big ones. What else?
5. Crohn's disease, 6. Lymphoma, 7. A psoas abscess, and 8. In females, ovarian pathology.
That list really underscores why we need objective data. So what's the standard sequence? Where do we start?
We start with the basic investigations. A complete blood count, CBC. We're looking for a high white blood cell count leukocytosis in acute infections.
And the general inflammatory markers.
Yes, the ESR and CRP. A sharply elevated CRP points to acute bacterial inflammation, like an abscess. A moderately but persistently elevated ESR is more often seen in chronic diseases like PB or cancer.
Okay, so we have the bloods. Now for imaging, what's the first-line visual test?
The first-line study is usually an ultrasound of the abdomen. It's fast, there's no radiation, and it's fantastic for differentiating a solid versus a cystic mass.
So it can tell you if it's an abscess full of fluid.
Immediately. It's the perfect initial screening tool.
But if we're worried about cancer in an older patient, or if the ultrasound isn't clear, we need to escalate.
Absolutely. The next step, and the gold standard, is the contrast-enhanced CT scan of the abdomen and pelvis, the CECT.
What does that give us that the ultrasound doesn't?
Phenomenal detail. It can pinpoint the exact origin of the mass, assess the extent of bowel wall thickening, identify enlarged lymph nodes, and, critically, it can look for distant spread metastases to the liver or lungs.
So if you suspect malignancy, a CT is mandatory for staging.
It is non-optional. You cannot plan a cancer operation without a comprehensive staging CT scan.
Okay, imaging has localized and characterized the mass. Now, how do we get the definitive tissue diagnosis? Because treatment really hinges on knowing the cell type.
For any mass where you're thinking malignancy, Crohn's, or TB, you need tissue. And the workhorse here is the colonoscopy with biopsy.
So you go in with the camera.
You go in with a scope. You look at the lining of the cecum and terminal ileum, and you take multiple tissue samples. You see the friable, ulcerated mass of a cancer, and you biopsy it. That tissue goes to the lab for histopathology.
And what if the mass is clearly outside the bowel, like a big lymph node?
Then we can do a targeted sampling with a fine needle aspiration cytology, or FNAC. We use the CT or ultrasound to guide a needle right into that node and aspirate some cells. It's a great way to get a rapid diagnosis for TB or lymphoma.
And just one last thing for tuberculosis. What's the simple, non-invasive test that can really support that diagnosis?
The humble chest X-ray. Intestinal TB very often coexists with pulmonary TB, active or old. Finding signs of TB in the lungs provides really strong circumstantial evidence that what you're dealing with in the abdomen is also TB.
So the progression is clear. Bloods, then ultrasound, then CECT for detail, and finally colonoscopy or FNAC for the tissue confirmation. It's a very logical pathway.
It is, and that leads us to the final step. What do we do about it?
Exactly. We arrive at the so what, we have the diagnosis, and now the entire management plan flips completely depending on that label.
This is where we transition from diagnosticians to surgeons and physicians. Let's start with the most common acute scenario, the appendicular mass.
So just to recap, this is the body successfully walling off a perforated appendix. But that presents a surgical dilemma,
A
right?
huge one. That whole area is this densely inflamed, fragile, matted together mess. If you try to dissect through that acutely, you risk tearing the colon, causing bleeding. It's a recipe for disaster.
Which is why immediate surgery is often the wrong answer, and we have the famous conservative approach, the Ochsner-Sharon regimen.
The rationale is simple. Give the body time to cool down. We wait 6 to 8 weeks for that acute inflammation to resolve on its own. The regimen itself is all about gut rest and infection control.
So what are the components?
First, nil per oral. Nothing by mouth to rest bowel. Second, IV fluids to keep them hydrated. Third, broad-spectrum 5E antibiotics to control the infection. And fourth, meticulous observation.
So you're watching them like a hawk. What's the sign that you need to abandon this conservative approach and go to surgery?
You abandon it immediately if the patient gets worse. If the mass gets bigger, if their fever spikes, if they develop signs of generalized peritonitis. But if the regimen works, the mass shrinks and the patient gets better fast.
And once they've recovered, what's the final step?
Interval appendicectomy. You schedule surgery 6 to 8 weeks later. By then, the anatomy is clean, the inflammation is gone, and you can safely remove the diseased appendix to prevent it from ever happening again.
Okay, now let's contrast that with the appendicular abscess. The mass has turned into a pocket of pus.
This requires a rapid, different response. Pus under pressure is dangerous and needs to be drained. You suspect an abscess if the patient is acutely septic, high fever, toxic, and the mass feels fluctuant like a water balloon.
And the intervention is drainage.
Immediate drainage. Usually we can do this minimally invasively with ultrasound-guided percutaneous drainage. A radiologist sticks a needle and a catheter into the abscess and drains the pus.
And you still take the appendix out later.
You still perform the appendicectomy 6 to 8 weeks later. Draining the pus doesn't remove the source of the problem.
Okay, let's move to the chronic diseases. Ileocecal tuberculosis. The management here is primarily medical, which is a big conceptual leap.
It is. The RIF mass from TB is a medical disease treated by physicians, not a surgical one.
So once you've confirmed it with a biopsy, what's the treatment?
Antitubercular therapy, or ATT. A multi-drug regimen for a prolonged course, typically 6 to 9 months. The goal is for the medication to completely resolve the mass.
So surgery is not the first line for TB. When do you operate?
Surgery is reserved strictly for complications. The 3 main reasons are: 1, bowel obstruction from the scarring; 2, perforation or fistula formation; and 3, failure to respond to ATT, which might make you question the diagnosis.
That's a core takeaway. Medical first, surgery for complications. Finally, the definitive management for ileocecal carcinoma.
This is a surgical disease from the very beginning. The profile is the older patient with weight loss, bleeding, and that hard, fixed mass.
After the staging CT, what is the curative procedure?
The standard of care is a right hemicolectomy. This is a big operation. You remove The last part of the small intestine, the cecum, the appendix, the entire ascending colon, and part of the transverse colon.
Why such a large resection?
Oncologic principles, you need clear margins, but more importantly, you need to remove the entire lymphatic drainage basin for that segment of colon to get all the potentially cancerous lymph nodes.
And after the surgery?
Adjuvant treatment. Chemotherapy is typically given afterwards, depending on the final pathology stage specifically, if the cancer has spread to the lymph nodes.
And just quickly, what about the other causes on our list?
For Crohn's disease, management is primarily medical with immune suppressants. Lymphoma is treated systemically with chemotherapy. And a psoas abscess requires drainage and long-term specific antibiotics.
So every single one of those diagnoses, though they present in the same square foot of anatomy, leads down a completely different path.
That's right. And if we connect this back to the beginning, what we've really demonstrated is the absolute necessity of a structured approach.
Yeah.
You have to use anatomy to frame the possibilities, the focused history as your primary filter, careful examination to feel the differences, and judicious investigations to get a tissue diagnosis.
And the power really comes from mastering the differentiation of those big three. So just one last time. If the mass is acute, tender, and firm, you manage it conservatively and delay surgery. That's your appendicular mass.
Right.
If it's chronic, doughy, and non-tender with systemic symptoms, you treat it medically first with anti-tubercular therapy. That's ileocecal TB.
Exactly.
And if it's hard, irregular, and fixed with red flag bowel changes, you prepare for a definitive surgical resection, a right hemicolectomy. That's ileocecal carcinoma.
Mastering that framework is what separates the confident clinician from the overwhelmed one. It lets you move quickly and safely towards the correct management plan.
We anchored this entire deep dive on the structures specific to the RAF because the ileocecal junction and the appendix are what drive this unique differential.
They are.
But the body is a continuous system. So here's a provocative thought for you to carry forward and mull over. How does this entire framework change when we just move across the midline to the left iliac fossa, LIF? What major structures dominate that side think about the sigmoid colon, and what specific disease, which often presents identically to this but requires completely different management, replaces appendicitis as the most common cause of an inflammatory mass on the left?
That requires shifting our entire anatomical focus, doesn't it? It just proves that in abdominal pathology, location really is everything.
It certainly is. Thank you for joining us for this deep dive into the RAF mass. We hope this structure gives you confidence in facing your next clinical puzzle. Until next time.